So there's a bit of science in this. This is why I got involved, because I like the science. I'm a pathologist. We study disease. Now, whilst that might be a whole lot of facts, those facts can be turned into information and knowledge, and that knowledge is of real value when it's applied. So that's what getting the facts in place and teaching people how to use them about. So we're talking about low carb, high fat diets, and I'm going to concentrate on the blood test for carbs and fats. And if you want to know more, certainly read Jimmy's book. So this is how fats float around in our blood in these spheres. Inside the sphere are fat or triglyceride and cholesterol stuck to triglyceride or cholesterol ester. Cholesterol stuck to fatty acid. And outside is this surface of other fats, phospholipids and cholesterol, as well as some protein, some big chunky bits to try to hold it together. But this is one of the spheres that we have in our blood. There are a whole lot of different lipoproteins, and they vary in size. We talked about small dense LDL, but you know there's something even smaller, which is high density LDL, the high density lipoprotein, which is the so-called good form, and then these gigantic spheres, which you make in the blood after a meal to transport all that fat that you've eaten to the liver and to your other organs. So to us, cholesterol is somewhere in there and fats are somewhere in there. We're more interested in what each one of those things do. So, as I said, from the intestine you eat fat and you make this big chylomicron particle, and then the tissues keep taking out the bits they want, and the bits that's left, the chylomicron remnant, goes to the liver. And then the liver itself can make its own fat from sugar, as we all know, but it can export fat and the cholesterol that it makes. It can export them. And the export particle, the expert sphere, is called VLDL cholesterol. This one here, VLDL cholesterol. Now, VLDL cholesterol is full of triglyceride. It's being packaged out so that the people who use triglyceride for fat can use it. And as the fat's being taken out of it, it gets smaller and smaller. So VLDL becomes LDL. And once it's given up all of its triglyceride and distributed a bit of cholesterol, it's finished and should go back to the liver and be recycled. Like a truck that's empty, go back to home base and fill up again. So this is all, now HDL is a bit of a mystery, this particle, so it just seems to form whenever there's lots of cholesterol around that needs to be taken back to the liver. But this is all natural. There's no blood vessels involved here. This is what nature intended for triglycerides and for cholesterol. So the liver's making VLDL, it's gradually being transformed. The intermediate density lipoprotein can go back to the liver. The LDL, the normal LDL, can go back to the liver. That's all health. And without it, there's people that can't do this, they're incredibly sick. So what is this particle that's full of cholesterol that ends up in blood vessels and blocks them? It's got nothing to do with nature. What can happen to LDL is, rather than going back to the liver, it can stay in the blood and change its character, change it to be smaller and harder, or be glycated or oxidised. And once LDL changes, the liver wants nothing to do with it. It's like a broken truck. I don't want those trucks back here. Tell the rubbish pits of the body to get rid of it. And if those rubbish pits happen to be anywhere near your blood vessels, that's a disaster. So let's think about a bit more detail about how these particles interact with each other, because that's important. So fructose can be converted to triglycerides in the liver, And as I said, normally you export that as the VLDL particles. It's a packet of fat that goes out to the tissue. But if you make too much of that VLDL, like there's so many trucks on the road, and nobody wants to use the fat, they just hang around in the blood. That's why you have high triglycerides in your blood, because the body doesn't want to use them. It's too busy using carbs. So if this VLDL particle accumulates, it starts crashing into the other particles. Well, first of all, fatty liver. So what predicts fatty liver? High levels of triglyceride, and there's these other things. Anyway, you probably have to listen to my other YouTubes there. VLDL correlates with triglyceride. So when I talk about this VLDL particle, it means triglyceride. You can tell whether you've got a lot of VLDL being made and not used if you've got high triglyceride. And just an issue, people often ask me, how do these numbers add up? If the total cholesterol's 6 and the bad cholesterol's 4 and the HDL's 1, well, 2.2 and 5 does not make 6. How do they add up to 6? We work out how much VLDL cholesterol there is from the triglycerides divided by 2.2. And as Jimmy said, that's a sort of a formula we use even when we don't have evidence for it, because there's no other way of trying to work out how much VLDL cholesterol there is. And we're not supposed to use that calculation when the triglycerides are too high, because, as I'm going to tell you, because when the triglycerides are high, the particles start crashing into each other and the whole formula starts breaking down. So here's this VLDL that people on high-carb diets make a lot of. And not only can it crash into HDL, but there's a protein that helps it swap bits and pieces with HDL. HDL is actually trying to help out this big particle that nobody loves and say, well, give me some of your triglycerides and I'll help you distribute it. But, you know, HDL is giving up its cholesterol ester, taking up fat, helping get rid of the fat, giving up its cholesterol ester, getting rid of... You know what happens to HDL in the end? It disappears. It gets worn out and disappears in its effort to help the LDL do its job. And so anybody who's got high triglycerides or high VLDL will have a low HDL. It goes hand in hand. If your triglycerides go up, your HDL will go down. If your triglycerides go down, your HDL will go up. And there's this inverse relationship. The higher your triglycerides, the lower your HDL. Now, that's pretty bad that you're messing up the whole job of HDL, but there's something even worse, because the VLDL, the fat triglyceride-rich particle, can crash into LDL, its child. And the child wants to help its parent and says, well, you give me some of your triglyceride and I'll help to distribute it, you know. And eventually, now LDL doesn't disappear and wear out with that, it just becomes small and hard. And that small subtle change in LDL that's been trying to help our VLDL, it means that it's abnormal. It changes so much that the liver says, no, you've worked too hard helping LDL. I don't want anything to do with you either. This truck is just worn out. You shouldn't have done that. And so we can predict who has small dense LDL from the triglyceride levels. So as your triglycerides increase, if they're above 1.5, this is the percentage of your LDL that's in the small dense form. And see, patients that have triglycerides of 2.5 or 3, virtually all of their LDL is in the small dense form that the liver wants nothing to do with. It has to hang around in the blood to find another home, and that home is probably going to end up being your blood vessels. There's just some other data showing when triglycerides increase, this is some of our own Australian data, when triglycerides increase, the percentage of small dense LDL just increases. So the problem with LDL is that we change it. We might change it by making it smaller, we might change it by oxidising it, you know, in those inflammatory terms, or smoking and oxidising it. And it has to be taken up by something, and it's taken up by the immune system, like macrophages, and the immune system sort of lines the blood vessels of the body, keeping security, like there's rubbish in that blood vessel, let's gobble it up. Yeah, but if there's too much rubbish, you're going to end up with all the rubbish in the blood vessel. These are just some pictures of actual, you know, LDL particles that are supposed to go back to the liver. They're going into the pits of the liver. If it's a small dense LDL particle, it won't go into that pit, it just comes straight out. And when we're talking about small, don't imagine that it's big and fluffy and small and dense. They're words that we use to exaggerate the situation. The difference is, if you can tell the difference between those two spheres there, that's the difference. Their difference in size by the same amount. It's a very subtle change in that size of the sphere that means the liver wants nothing to do with it. It's 26 nanometres compared to 24 nanometres. So, you know, the language we use is a bit exaggerating to say small and dense and big and fluffy. There's a very subtle difference that makes a big difference to the body. And when you have small dense LDL, as Gerald Reeve and Ron Krauss found, that presence of the small dense LDL correlates with all of the cardiovascular risk marker, your blood pressure, your weight, your insulin levels, your glucose levels. So it's right at the core of the problem, this disturbance. Now, as Jimmy said, you can get it measured in some places in America by NMR. It costs $167. Probably costs you more to transport the sample to America. And for the last 10 years, there's been a lab in Melbourne, the Sydney Adventist Hospital, that's been doing these tests. And I just want to show you a little bit about the test. It's fairly simple. It's got you put a drop of blood on top of a gel, and depending on how small the particle is, it'll go deeper into the gel. It's as simple as that. It gives a beautiful coloured explanation. And here we have all of the particles in this patient's blood. So here is the smallest particle, got right into the gel, that's the HDL particle. Here is the next smallest particle, which is LDL, and there's a particular, that's the bad LDL, the small and dense. This patient fortunately hasn't got any, and the normal LDL in the yellow. Up this end is this VLDL particle, the triglyceride-rich particle. And in here is something called the intermediate density particle. Remember that VLDL has to become LDL? It goes through this intermediate density form. Now, when we use the Friedewald equation, we assume that nobody has any IDL. But everyone has IDL. So this is sort of bringing into clear light the fact that we've been making the story too simple, not only in terms of good and bad, but all the different forms of LDL and the presence of this other particle called IDL. Now this patient here is not so good. This patient here has got this LDL form, which is smaller. It's got deeper into the gel. That's small dense LDL. And they can quantitate in the report. That red part is what you don't want to see. And normally, the small dense LDL should, this is the IDL. So you remember the IDL that's normally, well, we assume there's none there. Well, up to 1.5 of that 6, remember the 6 millimole per litre of your total cholesterol, up to 1.5 of it is normally IDL. But it'll never be seen on your standard lipid profile. We just ignore that fraction. And it accounts for a significant part of your triglycerides. You can tell from the triglyceride level whether you've got IDL present as well. So this whole issue of, you can't calculate, all of this is just a game that we've played. And the game has been causing a lot of damage, and it's trying to stop playing this game. Okay, so here's some results of some patients who've been on low-carb, high-fat diets, and they've changed their lipid profile. So cholesterol 6.5, triglyceride 1.6. In Australia we say that should be under 1.5 rather than under 1.8, as Jimmy said. So it's borderline at best. And the HDL is 1.4. The LDL, which is what the doctor's really worried about, is 4.2. And this patient has 11% of that LDL in the small dense form. And we could have predicted that because the triglycerides are a bit high. Anyone with high triglycerides has small dense LDL. So they go onto the low carb, high fat diet and their triglycerides fall, their HDL improves because the trigs aren't consuming those particles, and the small dense LDL has virtually disappeared. Now even I do not know how to interpret, but their IDL hasn't changed because nobody's interested in IDL yet. So triglycerides over 1.5, that's 35% of men in Australia in the last survey and 22% of women. 35% of men in Australia have small dense LDL in their blood and it's ending up in blood vessels and causing atheroma. That's what the problem is. Here's another patient. Cholesterol 5.2, LDL 1.5. The doctor said, oh, that's fantastic, you don't need a statin, you're perfectly okay. The triglycerides were 2.1. Even though they've got a low level of LDL, 17% of it is in the small dense form. So they go onto a low carb, high fat diet and the cholesterol increases and the LDL increases and really freaks the doctors out and everyone, but their small dense LDL has disappeared. And that is the literal bottom line in terms of this patient's cardiovascular risk. A similar example of patient. Now this patient here, even though they got the benefit with the trig falling and the small dense LDL falling, they didn't have a cholesterol rise on the diet. The LDL didn't really increase too much and the total cholesterol didn't hardly change at all. And look at the IDL, it was low and fell even lower. Now, I'm just showing you that there's a lot more information that we don't understand. Why does one person go up and the other one not go down? Why does one have a high IDL and the other one doesn't have a high IDL? As soon as we start measuring cholesterol in a proper way, we'll be able to understand each person as an individual. Now there's been lots of studies of the low carb, high fat diet. Here's this lipid profile in low carb, high fat diets. And what they did is studied some people that they truly put onto a low carb, 3 grams per day and 71% fat. And their cholesterol increased, their LDL increased. That's what most people do on a low carb, high fat diet. Their cholesterol and their LDL cholesterol will increase. But their HDL increases, and these patients actually started off with a really healthy triglyceride and didn't change. So most people sort of look at that and say, well, the cholesterol's increased, the LDL's increased, that's bad. Don't go on this diet. Because they haven't gone to the next step to say, but how has the LDL changed? Now I've tried to have some diagram. This is what normally happens. Remember, LDL's being made, VLDL's being made, it's being transformed to IDL as the body should take the fat out of it, and then eventually to LDL. And both the fragments, the bits that are left, the IDL and the LDL, go back to the liver. That's the healthy way that the body should work. In a high carb diet, we're making lots of VLDL. The tissues don't want any of the triglyceride, so we're not making the IDL or the LDL. And the VLDL's hanging around, crashing into LDL and making small dense LDL. So what happens in a high fat diet? In a high-fat diet, whenever we make VLDL, the body's using fat. And it'll convert it quickly to IDL and quickly to LDL. And in a way, there's more traffic going through this fat cycle and making more LDL. And that's why LDL should increase on a high-fat diet. You're generating more LDL, more happy, natural LDL. And it should increase because of the traffic. So every survey we have shows, in general, most people on a low-carb, high-fat diet will have a higher total cholesterol, a higher LDL, but their triglycerides will be lower and their HDLs will be higher. Another randomised trial. So triglycerides fall, cholesterol, if anything, rises, LDL, if anything, rises, and HDL rises, which is good. Another study. I'm just showing there's lots of studies with truly low-carb diets, which generally show that low-carb tends to result in greater weight loss, more of a triglyceride fall and more of an LDL rise than any low-fat diet. Now this studies here, they've gone that extra step. Yes, cholesterol, in this study the cholesterol didn't really change very much, but it actually fell statistically. The triglycerides fell a lot and the small dense LDL disappeared. That was the bottom line that we wanted to hear. That's the big benefit of the low-carb, high-fat diet, that the small dense LDL, that rubbishy form, which can get into blood vessels, disappears. High-fat diet, another study from 2012. Now the carbs in this diet weren't that great, but they still saw a decrease in small dense LDL. So the recent studies where they're looking at the important thing rather than the cholesterol and the LDL, they're looking at the important stuff, which is the HDL triglycerides and the small dense LDL, they're showing this important benefit. So the more your triglycerides fall, the bigger the bigger your LDL becomes, if you like. It's not small and dense anymore. It's another relatively recent study. So in my results, these are my cholesterol results for the last 30 years. I said before, I live in a laboratory. It's easy for me to get tests done. I've been testing myself for 30 years. And yes, most of my colleagues have been saying, oh, Ken, your cholesterol of 6, you know. I've been sort of, oh, look, nobody in my family's ever died of a heart attack. I can live with it. So I did get onto a statin at one stage, but I hated it, so I stopped it. Anyway, so then I went to low carb, high fat, and apart from one value which seemed to be small, I don't know what, I think that was about 1 or 2 months into the diet, it fell, but then it came back up to 6. So my total cholesterol didn't change on the high carb diet. I was expecting it to rise, like most people, but it didn't change. My LDL, which was 4, you know, above 3.5, that's why they want to put me on a statin, you know, this is bad, Ken. It should have increased on the low carb, high fat diet, and it fell temporarily, but it's still around 3.5, 4. My HDL level, which has always been 1, is our cut-off in Australia for men, which has always been just hovering around 1. You know, you really want to be above 1.5. Once I went onto the low carb, high fat diet, I went to 1.4, 1.6. It's actually 1.8 now. There is no drug known in the world that will increase somebody's HDL from 1.0 to 1.8. But that's what a high fat diet can do. And my triglycerides, which have been way over 1.5 for most of my life, are under 1 now. 0.8 is the lowest I've got. And I have mentioned my small dense LDL, there's none. There's none. So, you know, a couple of papers just to say that I haven't got diabetes, but this diet's been tested in diabetics and it has the same benefits. Not only improvements in triglycerides and HDL and small dense LDL, but also a fall in the hemoglobin A1C. And the low-carb, high-fat diet has a greater benefit in the hemoglobin A1C, which I'll explain in a moment, than does a calorie-matched high-carb, low-fat diet. So hemoglobin A1C is the red colour in your blood is hemoglobin, and when sugar's sticky, it sticks to everything. And it sticks to the red colour in your blood. That's hemoglobin A1C, means more or less glucose stuck to it. Here it is here. And the handy thing about hemoglobin is that it hangs around in your blood for 3 months. So the amount of glucose that's stuck onto your hemoglobin reflects what your glucose levels have been for the last 3 months. So it's a very handy way to judge. Now, if you go onto a low-carb, high-fat diet and improve everything within weeks, the hemoglobin is not going to A1C is not going to change because it remembers all the glucose levels that you've had over the last 3 months. So the hemoglobin A1C takes at least 3 months to change after a low-carb, high-fat diet. I haven't got my results in a graph, but my A1C wasn't too bad. It was 5.4, which is upper limits of normal. It fell to 5.2 after the first 3 months, and I thought, oh, that's not very impressive. Well, it's now 4.8 because it's a year later. So you just have to have a bit of patience with the glucose levels and they'll show the improvement. So hemoglobin A1C, such an important figure, at least as important as triglyceride, because the amount of sugar stuck to hemoglobin, i.e. the average amount of glucose in your blood, as the hemoglobin A1C level rises, so does your risk of coronary disease, of dying, of heart attacks, of strokes. It rises exponentially. Now, we say that when your hemoglobin A1C is above 6.5%, you have diabetes. You've not only got a really high risk of cardiovascular disease and so on, but you've got the risk of eye disease and kidney disease and so on. We want to get that A1C down out of that danger zone. But the cardiovascular risk didn't start to rise when you were diabetic. It started to rise way back here. That represents years and years before you develop the diabetes. So most people that have heart disease or heart attacks in Australia are not diabetic, they're pre-diabetic. They're on the pathway to diabetes, but the heart attack got them first. So the way to interpret the hemoglobin A1C, in general terms, because labs are slightly different, 4.5 to 5.5% is what your A1C should be if you want to be away from cardiovascular risk, away from that progression to diabetes. If you're in the 5.6 to 6.4 range, you're on the road to diabetes. You have to do something. If you're above 6.5%, you've got diabetes, but there is hope there. If you're a young diabetic and you get everything right, you can cure yourself of diabetes. If you're older, it's a bit hard to do because the islet cells have been worn out. And certainly, this is the only thing we used to concentrate on 10 years ago. If your A1C is above 8 and you're diabetic, you need to do something. So A1C not only correlates with outcome, but it correlates with high triglycerides, low HDL, and if we had a small dense LDL there, I'm sure that it would rise as your HbA1c rose. So a non-calorie restricted low-carb diet is effective a treatment for type 2 diabetes. So if you put diabetics onto a normal diet, they might get a bit of an improvement in triglycerides, probably not. A1C, probably not. Low-carb diet, massive improvements in triglyceride, therefore small dense LDL, and major improvements in hemoglobin A1C. Just some other things to mention. This is a low-carb study or a dietary study with diet and exercise, 3 weeks. In those 3 weeks, they could change. It doesn't take much to drop triglycerides, to decrease small dense LDL. You can do it in 3 weeks. But as soon as you leave that place, where they did the RESOLVE trial, and you go home and resort to your own diet, it'll come back. Not necessarily with a vengeance, but it'll come back. So as we've said all day today, this diet's magical, but you have to stick to it. It's not a 2-week cure. This is a lifetime decision. Now, just some last things, and these are important issues. A lot of people have contacted me regarding lipid levels. So here's somebody on low carb, high fat, cholesterol 7.9. Trigs are great, HDL's great. The HDL's quite high, but this cholesterol's a bit high. And normally when a doctor sees that, he does start thinking you've got a genetic disease with your cholesterol level. Once it gets to 8 or 9, they think, oh, you've definitely got a genetic disease. So now I don't know why, I didn't know, why some people on low carb, high fat can have these massive rises in cholesterol. Here's another one, 4.7, 4.6, low carb, high fat, 9. Now 9 usually means familial hypercholesterolemia, you're going to have a heart attack by age 40 and die. So doctors are entitled to worry about a cholesterol of 9. It is reassuring that that triglyceride is low, HDL's high, so we can sort of say, yes, the LDL must be in a small dense, not in a small dense form, in a large, buoyant, healthy form, the natural form. But I wish we understood it. Another patient, low carb, high fat, 6.4 to 9.3. And here we did measure something called lipoprotein little a. And that is a genetic form of LDL. This patient did have a genetic form of LDL which they find hard to get rid of out of the blood. And when you go low carb, high fat, more of it appears and it doesn't clear. And that I was thinking, well, that makes sense. Patients with high lipoprotein little a may get this exaggerated response to low carb, high fat. And then I got another patient with, well, this is just another patient with the same sort of rise. So what is, I thought I did have another patient with a high, oh no, there it is. There's the lipoprotein little a. So it should be under 0.3, it's 4 times normal, and it's increasing as well. So this is lipoprotein little a. It's an LDL particle. Remember, LDL's good. It's just a good LDL particle. But for some reason, nature or genetics have said, attach this thing to it, which is the ApoA protein. So it's got this tail on it's like literally a tail on the LDL particle. And when the liver sees this particle, it says, oh, well, nothing to do with you. We don't like tails here. And for some people, we don't know, it might end up in your blood vessels. Now, this is a small proportion of the population. It's only a few %. But if I see a patient on a low carb, high fat diet have this big rise in cholesterol, LDL, I think you need to measure the LP little a. And then we can decide what to do. So the concept here is that here's the normal pathway, so VLDL, IDL, eventually everything gets back to the liver. But what happens if there's a problem with that final step of get the LDL getting back to the liver, like lipoprotein little a? It's going to accumulate. So we need to measure the LP little a. There are other sort of genetic abnormalities of ApoB that might occur. Here's a patient, most impressive of all, 5.7 to 16. A cholesterol of 16, it usually means what we call homozygote familial hypercholesterolemia. These children die of heart attacks. This lady was not a child. She was postmenopausal. She didn't have familial hypercholesterolemia. She didn't have a high cholesterol. The low carb, high fat diet brought this out. And she didn't have lipoprotein little a. So I don't know why is her LDL accumulating under the impact of the low carb, high fat diet. And there may be other reasons for LDL to clear. Thyroid disease does affect how the LDL particle goes through the body. We've known that patients with hypothyroidism have high cholesterols and higher LDL. Maybe the mixture of thyroid disease and low carb, high fat maybe having a relationship. And there are other things too, because this IDL particle, because we have to test her IDL, maybe this is all IDL. Because the IDL particle relies on a different receptor to the LDL receptor. It relies on the ApoE receptor. And many of you will know that we can genotype patients for the type of ApoE there is. There's 6 different types of ApoE genotypes. And it could be that is also a determinant of who gets these massive rises of LDL on the low-carb, high-fat diet. It's only a few percent of people. I think it's truly less than 5%. But it is, as far as most doctors are concerned, one of the risks of the low-carb, high-fat diet. So I would recommend, particularly with anybody with a family history of heart disease that go onto this diet, once you go onto it, in a month or two, check your lipid levels to make sure you're not one of these. It may be harmless, but it's best to know about it rather than 2 years down the track somebody sees your cholesterol level of 16 and think, what the hell are you doing? Okay, and so getting back to, this patient here who had the cholesterol rise, I think I showed them to you before, but I didn't highlight the IDL. This patient's IDL went from 0.3 to 1.9 on the low-carb, high-fat diet. So presumably they've got some sort of ApoE issue, which means that the high-fat diet's resulting in a higher level of IDL. Nevertheless, I'd still encourage this patient to stay on the diet because look at the small dense LDL, it's disappeared. So in summary, low-carb, high-fat diet decreases small dense LDL. That's what its benefit is. It does that because it decreases triglycerides, at the same time it increases HDL, and for both healthy people and for diabetics, it'll decrease hemoglobin A1C. They are the fantastic benefits of the low-carb, high-fat diet. But it does increase cholesterol and LDL, and perhaps IDL, in most people, and some people to an exaggerated extent. And remember I said I'm a pathologist, I need to understand why, so that I can reassure you that it's not harmful. Thanks.